I'm very honored to be here, and I'd like to thank the organizers for inviting me to come to your beautiful city here and to your great congress. I already love the auditorium here. I have to tell you that I'm sorry that I'm the last speaker before lunch, and I have 86 slides to go. So please tell me if it's going to last too long, but I think it's worse to be the first speaker after lunch. So we'll try to see where we get. And actually, I'm going to use 86 slides, but I'd like to leave you with the take-home message or think about message or sleepover message. And those are two things. Ultrasound is the way to go for internal medicine, and acute internal medicine is becoming a very important branch on the tree that is internal medicine. So let's start first by saying a little bit about the European Federation of Internal Medicine. The European Federation of Internal Medicine is a unique organization. All the European internists are working together within this federation. And I always say, standing here, I represent 40,000 European internists. Problem is that 39,000 don't know that I do that. But still, I think it's very important that there gets more cooperation within Europe. And I've been invited to talk about ultrasound and internal medicine. And actually, 2016, it's a bit of a special year because it was 200 years ago that René Laennec, he invented the stethoscope, and he did it by accident because he had to investigate a woman who had rather large breasts. And in those days, you were used to put your ear on the thorax of the patient, and he was a bit hesitant because, okay, so he designed a ruse, and he asked for a newspaper, and he rolled it, and then he listened, hey, and he said, it sounds better than it used to be by direct comparison. But it's been 200 years, and the stethoscope is still the thing that we wear around our neck and that we still use. And one of the problems is that, well, I know there are two very good doctors here sitting behind the table, but I'm sure if we would have a patient with a pneumonia here and we would both send them with a stethoscope, and not hearing what the result would be, if I would ask Antonio, what do you hear? He would say something like, I hear some rails, or I hear something else. And then I would ask the president of the Congress to go and listen, and she would come up with a different pronunciation of what she heard. And problem is, of course, that if you visit this same patient the next day, you will not be able to compare what you heard. So ultrasound is very important for internal medicine, and I'm going to talk on a number of subjects. And I'd like to first ask in the audience here, anybody still using a stethoscope? Please raise your hand. Okay, I don't anymore. Anybody using ultrasound on a daily basis? Please raise your hand. Ah, very good. So there is a little bit of work for me to do, but I do have some disciples already if we are on a mission. And I'm going to talk about cardiac ultrasound, lung ultrasound, abdominal ultrasound, vascular ultrasound, and a little bit about Doppler. And I'm not going to be too technical. But first, I'd like to make a disclaimer, because when we were starting ultrasound, we were getting into troubles with our radiology department. They were saying, hey, you're taking away my bread, and we are much better than you are, and you will never be as good as I am. And so I'd like to make a statement up front. I don't want to be as good as the radiologist. I use the ultrasound to answer clinical questions. Like a clinical question is, why is this patient in shock? Like a clinical question is there pericardial fluid, yes or no? I don't want to know if there's a full-blown tamponade. Of course, if I see a lot of fluid, I'll ask the cardiologist, please come and look with me, and we investigate together. So I always say to the radiologist, no, I will never be as good as you are, and I'm not a threat to your profession. So that's just to keep them quiet. So basically, I'm not very interested in pure anatomy. I'm not interested to find this 1 centimeter large lesion in the liver. No, I'm interested in physiology. I want to know Not if there is a small tumor. I want to know, is there a serious aortic problem? Yes or no. I want to know what's the reason of the shock. So ultrasound for internal medicine. Of course, if you start doing ultrasound, you have to learn a lot, because suddenly you're looking at a different way at patients. You need to cut through organs instead of looking at them. For instance, if you make an image of the heart, like here, this is a standard image of the heart, you need to realize that you cut through the heart, and that's what you're seeing. Of course, this had many disadvantages because the learning curve is rather long, but I can tell you it's also steep. Sorry about that. Also, in other projections, you cut through the heart. So, for internists, we have a number of indications why we want to do cardiac ultrasound. I want to know, why is this patient hemodynamically unstable? I want to see what is cardiac function. I want to see, are there any large pulmonary problems, yes or no? And I'll talk to you later and show that it's very good to do this with ultrasound. I want to know why this patient has shortness of breath. Why does he have an acute renal insufficiency? Is there abdominal distension, etc., etc.? So there are a number of things that are very important. First question, is it reliable? Can it be done with point of care, a hemodynamic ultrasound of the heart? Is it reliable ultrasound by internists? Cardiologists will say, no, this is my field, you cannot go. There is good research out there that the cardiologist with the stethoscope is worse than an internist with an ultrasound probe, even after only 1 or 2 days of basic training. And if you would like to come and work in my department, for instance, you will not be allowed to work there before you have done your ultrasound course. With regard to the reliability, yes, it is very reliable to rule out abnormal findings. So is it useful? Yes, it's extremely useful, because it very often leads to a change in diagnosis, and eventually it leads to a good correlation with the definitive diagnosis. Is it possible? Can we do it in every patient? No, we cannot do ultrasound in every patient. Sometimes it's hard to get good images. Sometimes of the 4 standard images of the heart, you can only get 1. But basically, in most patients, you can get good images. Every now and then you need to revert to esophageal ultrasound, but it leads to a change in policy in rather a lot of cases. So these are some images that you might normally find. Here you see a 4-chamber image of the heart, where you see a very large left ventricle. I'm not going to overwhelm you with images, but I'm just going to show you a few examples. We also use ultrasound for determining fluid status of the patient. Here we make a transection of the inferior caval vein, and we look what the diameter of the vein does if we ask the patient to take a breath in. And I can tell you with certainty that this patient is not fluid overloaded, because the diameter of the inferior caval vein changes with respiration. So let's see, this is a Windows computer, I apologize for that. I don't think this movie will run faster than it does, but basically, there it comes, okay. So basically, what you see here is a normal left ventricular function with a good contractility and a not enlarged right ventricle. So this is what you must learn if you start cardiac ultrasound. You see another way that you look at the heart, you transect it, but the large abnormalities you can determine rather easily. So this is another section through the heart. Okay, you see here a normally contracting left ventricle. So it helps in making diagnosis, and it helps in choosing what treatment we need to take. So, for instance, I have here a few slides where you can easily compare normal images with abnormal images. Anybody willing to guess what's abnormal in this picture? Just after my 5 minutes of introduction. Yeah, the left ventricle is compressed by an enlargement of the right ventricle. So if a patient would come in being very short of breath, and I would find this ultrasound picture, and I would also have some clues in the history that he might have a pulmonary embolism. If the patient is in shock, this image is enough for me to give thrombolysis. I do not need more, and I can make the diagnosis myself. I do not need a cardiologist. Of course, I might ask him, but this is pathognomonic of acute right ventricular pressure overload. And this is where you see a movie. You see here the septum, and it's displaced to the left side from the right side, acute right ventricular pressure overload. I'm sorry about the movies, they don't run very fast on this computer, but... And here you see a patient whom we had resuscitated on the ward, and you see here pulmonary emboli in the right ventricle. This is a different projection where it's called the acute internal medicine view in the upper abdomen. And here I do have a view for you with some pericardial fluid, but sorry, the movies don't run that great. This is a standard view from the left side of the sternum, where you see here the mitral valve, you see here the right ventricle, and you see some pericardial fluid there beyond the right ventricle. So these are things I think that internists should all be doing. Here you see an inferior caval vein. It is too large, there's probably some fluid overload. So there are some criteria through which we can ourselves diagnose a cardiac tamponade, and I think that it's shifting a little bit from that it used to be only for cardiologists to diagnose it, but nowadays internists can do these things by themselves. So we use it to determine the cause of hypertension, to determine the cause of jugular vein distension, and we will use it to get an impression of the fluid status. Like I showed you earlier, here you see the right atrium, here you see an enlarged inferior caval vein, and here you see these movements with respiration. And here you see a collapsed caval vein signifying dehydration. So this is, well, I think most of you have been to a cardiology lab, most of you have seen cardiac ultrasound. Has anybody been doing pulmonary ultrasound? 1, 2, 3, okay. I'm going to tell you something shocking. Pulmonary ultrasound is far superior than X-ray, which you make daily of your patients. People always thought that air was the enemy of ultrasound, but we can determine a lot between the skin and the pleura and beyond. In my department, we hardly make any X-rays of the thorax anymore. And we answer our questions about the pulmonary ultrasound with yes or no. We want to know, is the pleural fluid, yes or no? We want to know, is there a pneumothorax, yes or no? And we want to know, is there a pneumonia, yes or no? And ultrasound will help you far better than your X-ray in determining this. It has a number of advantages. You can do it at a website. It's a dynamic investigation. It's easy to repeat. Of course, you will not see intravascular lines, even though we just finished a study where we stopped doing an X-ray after putting in a central line. It's far more, it's extremely good in diagnosing pneumothorax, pleural fluid, and even a partial pneumothorax you can diagnose with the use of ultrasound. So I'll give you a short course on this subject. And here you see a rib, there you see a rib, here is skin, there are muscles, and there is fat, and beyond here you see this image. So here's the pleural line, and this is mostly an abnormality. So we look for the pleural line between the ribs, and we want to know what's going on there. And now I do hope that this movie does run. What you see, what you're going to see is what we call lung sliding. You will see the pleural, the visceral fluid sliding along the parietal pleura. There you see it. It's like a curtain that's been drawn from one side to the other. Does everybody recognize it? Yes? This proves ventilation. This proves that the visceral pleura is sliding along the pleural fluid. So so there cannot be a pneumothorax. This is the pleural line, and what you have to think about is that this below here, I'll give a real course if anybody is interested, is not really existing. These are reverberations from the area above. So mostly you see the area from the skin until the pleura and not much beyond. So let's see what Here again you see lung sliding. Everybody's now familiar with it. You've seen it once and you recognize it immediately the next time. So this is a patient who is fluid overloaded. And here you see a lot of lines going down. And that's just fluid which is being seen by the ultrasound machine, and this creates this kind of comet tails. 1 or 2 comet tails per intracostal field are allowed, but more than 3 are diagnostic of pulmonary edema. Pulmonary edema. And this is a video of a pneumothorax. You've seen a couple of videos ago that you saw the curtain going from left to right. And here you see the area below not moving when you compare it to the muscles and the fat. So what you will have to learn is that what you see down here is only reverberations from what you can see here. I can give an extremely complicated explanation, but that's what it is. This really doesn't exist. So this is a complete pneumothorax, but you see there is no sliding of the pleural, of the visceral pleura along the parietal pleura. I'm not going to this. This is maybe a bit too complicated. So there are a number of locations where we do the scanning on the front of the thorax, on the first axillary line and the dorsal axillary line. First, we try to determine if we see lung sliding and if we see these B lines of fluid, and there are some other techniques, but they go a little bit far. So this is a picture of pulmonary edema, and this is a picture of pneumonia. So in the first area you only saw some black, but now you see a lot of light. And it is my statement that if X-ray of the thorax and ultrasound would be invented at the same day, you would be making ultrasound of the lungs and hardly any X-ray at all. Okay, so ultrasound is very good for determining pleural fluid. It's far better than an X-ray. Because an X-ray, you go and study the X-ray with your radiologist or urologist, said there may be some pleural fluid. With ultrasound, you're sure that there is pleural fluid, but furthermore, you can determine whether it's a transudate or an exudate. So this is where you see the liver, this is the diaphragm, here is the lung, and here is pleural fluid, clearly visible. Here again, pleural fluid, diaphragm, diaphragm. And here you see an empyema. So here is again the liver, here's the diaphragm, and here you see an empyema. All these X-ray of normal fluid, of empyema or pneumonia, they can all look the same. But with the use of ultrasound, you can determine what is really the cause of the problem. And here you see a small fibrin adhesion in the pleural fluid, just for fun. So there is a decision tree that has been created for the acute patient who is acutely short of breath. And of course you take your history and you do a physical examination, but you do nowadays, in my view, the physical examination with the ultrasound probe in your hand instead of the stethoscope. And then you come through this simple decision tree to determine what is the problem. And you put the ultrasound probe on, you see lung sliding, you know there is no pneumothorax. This is what you know with absolute certainty. If you don't see the the lung sliding, it is a pneumothorax, probably, but it might be, well, something else, with some few steps, which are a bit too complicated for now, but with a few steps, you can come to the correct diagnosis, whether or not there's a pneumothorax, yes or no. So we come to ultrasound and vessels. How much time do I have? 5 more minutes? More. Okay. The people who use ultrasound, do you use it for putting in central lines? Yeah, that's what you do. Okay. For people who don't use ultrasound and put in central lines, they're doing very dangerous things. This is the carotid, and in studies it has been shown that this is the most often occurring position of the internal jugular vein. But the other positions are also possible. And last week I had a patient refer to me from the oncology department, please put in a central line, and I put on the ultrasound, and there was a thrombus in the internal jugular vein. So you can try for half an hour, but you will not get a catheter into that internal jugular vein. And studies have shown very clearly that with the use of ultrasound, you see what you're doing. And I think the time has come to stop doing things that we don't see. I would like to make a statement that it's, in 2016, unethical to put a needle somewhere in a patient if you don't have ultrasound in your other hand. So, everybody agrees? Okay, thank you, thank you. Okay, so I don't, I don't think we should do anything blindly anymore. It's been proven, really proven, that just doing it by landmark technique does not work, and that you can see what you're doing if you're using ultrasound. And everybody knows the internal jugular vein has such a collapsible wall that if you are not careful, you will compress the front wall to the rear wall and go through the vein inadvertently. And here with ultrasound you can see exactly what you're doing. In my department, you're not allowed to put a catheter into any vessel if you don't use ultrasound. So ultrasound will determine whether there is a thrombus, yes or no. This is the artery. Here is the internal jugular vein. It's thrombosed. Ultrasound will determine with certainty whether you're dealing with an artery or with a vein. And you can also use color to determine that also. Ultrasound is also useful for putting in central lines in the subclavian vein, but that's a little bit hard. You need a lot of training before you can do that. Radial artery, also, people mostly put in radial artery catheters blindly. You just feel the pulse and you put in your catheter. Nowadays it's been proven that with the help of ultrasound, this is far easier. Okay, I think that using ultrasound is a must for insertion of anything into a patient. And since using ultrasound, I have becoming a doctor who's become very afraid. You can not just start, you must go on courses. You must go on accredited courses before you can start using ultrasound. There are some international guidelines for that. And there are some international protocols. The blue protocol is for the acutely dyspneic patient. And these are protocols that are used in trauma patients. And this is a protocol that's used for the unstable patients. So in my view, I'd like to conclude that ultrasound in internal medicine is for physiological diagnoses, shock, pulmonary embolism, etc. It is time to replace the stethoscope. It is to answer questions with yes or no. Is there a post-renal obstruction? Yes or no. I really don't want to know how serious it is. Is it there? Yes or no. It will replace X-ray of the thorax to a large extent. Of course, you need some, every now and then, some indication for a thorax. But for instance, if we have a patient with a pneumothorax, with a thorax drain, it is forbidden in my department to send the patient for X-ray. The junior doctors, they go to this patient with the ultrasound probe every day and see whether the lung sliding has returned, yes or no, and then the drain goes out. And it leads to rest radiation damage for the patient. To see what you are doing when you puncture anything for patient safety, I think it is very important. So in my view, I think it is very important. And also it's becoming cheaper, and we get simpler devices. Okay, thank you. This was about ultrasound.